Hello, my name is Sayed and I will be presenting patient case. We have a patient presented in the clinic with a complaint of depression and the desire to take control of his life again. Richard Taylor is a 54-year-old gentleman presented in the clinic with a severe sign of depression. His depression started almost 3 years ago when he had a cardiac event. However, the last 6 months has been incredibly tough for him. He has no interest in his hobbies and constant feeling of guilt, fatigue, and worthlessness. Also, he is less inclined to spend time with his friend and recently has troubles in concentrating at work. RT has no sign of suicidal thoughts, bipolar disease, mania, or anxiety. He does not express any symptoms of insomnia. He tried citalopram in the past, but had to stop due to erectile dysfunction and diarrhea. RT likes to get a treatment for his depression, and if he can have a control on his depression, he may quit smoking and go back to exercise routine. His past medical history includes obesity, dyslipidemia, myocardial infarction, COPD, and active smoking. Here we have no information for drug allergies. For current medication list, patient currently taking metoprolol 16 50 milligrams PO once a day, albuterol 2 puffs every 4 hours as needed for shortness of breath, atorvastatin 80 milligrams PO once a day, fluticasone 100 micrograms 1 inhalation twice a day, aspirin 325 milligrams PO daily. His social history include he's a current smoker and smokes 1 pack per day. He drinks alcohol occasionally. However, in the last 2 weeks, he has been drinking more. He does not exercise. His diet includes increased calorie intake over the last 3 months, and as a result of this, he has gained 15 pounds in the last 6 months. His family history includes depression and cardiovascular disease. The prioritized problem list is his depression, COPD, and his habit of smoking. The last priority would be myocardial infarction and dyslipidemia. Moving to assessment of disease, starting with depression. As per DSM-5 criteria for depression, patient has severe sign of depression. This is evident by the fact that patient has depressed mood, anhedonia, loss of energy, worthlessness, and guilt for over 6 months that fulfill the DSM-5 criteria for depression. The contributory factor for his depression is the recent passing away of his wife, family history of depression, and his continuous deteriorating health. Patient is complying with all of his current medication for different diseases. Patient would like to get the treatment for his depression that will improve his overall health. Patient tried taking citalopram in the past, but had to stop due to erectile dysfunction and diarrhea. Considering all these factors, the goal of treatment is to manage his depression that will help him take control of his life again. Assessment of current therapy. Currently, patient is not taking any medication for the treatment of depression. 2 years ago, patient had tried citalopram but had to stop due to side effects such as erectile dysfunction and diarrhea. There is a need to start an antidepressant and psychotherapy such as CBT that will help treat his depression. Assessment of planned therapy. Citalopram 40 milligrams is not an appropriate choice for the treatment of depression in RT. The usual starting dose of citalopram for the management of depression is 20 milligrams in individuals less than 60 years of age. This dose can be gradually increased to a maximum dose of 40 milligrams in an interval of 1 week, and it depends upon the response and the side effects. In addition to this, patient currently have increased QTc of 457 milliseconds. This makes citalopram not an appropriate choice, as there was a report in 2015 by FDA that citalopram was associated with QTc prolongation. Based on these facts, citalopram is not an appropriate choice for this patient. Goal of therapy in this patient is to achieve the remission of depressive symptoms and restore optimum functioning in 6 to 12 weeks. The contributory factors for his depression is continuous deteriorating health, since his cardiac event in 2015, recent passing away of his wife, and a family history of depression. Management and plan. Recommendation number 1. Start venlafaxine 75 milligrams PO once a day for 4 weeks. Depending on the response and side effect, the dose can be increased after 4 weeks in increments of 75 milligrams to a maximum of 225 milligrams once a day. The rationale behind that is, as per APA guideline, for depression, venlafaxine is the first line of treatment. Venlafaxine is a safe and effective choice in patients with a history of cardiac event, such as MI, as per APA guidelines for the treatment of depression. Venlafaxine is also not associated with QT prolongation in patient with a history of QT prolongation. Recommendation number 2. Start CBT sessions with a therapist at least once a week for 6 to 10 sessions. As per APA guidelines, CBT therapy along with pharmacotherapy is more effective than pharmacotherapy alone for moderate to severe depression. Antidepressant usually takes few weeks before it will start working. CBT session will help patient to cope with the symptoms of depression during and after this time. The monitoring plan, starting with the efficacy. The efficacy of the treatment of depression in this patient can be monitored by improvement in energy and concentration in 2 to 3 weeks of initiating therapy. If there is no improvement in the symptoms of depression in 2 to 3 weeks, reassess patient and increase the dose of venlafaxine. From week 4 to week 8, patients who see improvement in the feeling of worthlessness with the continuous use of antidepressants. Once beneficial effects are seen from the treatment, continue pharmacotherapy for 12 months. The safety, we need to monitor side effects from venlafaxine, such as nausea, insomnia, and dizziness. The patient education, patient need to adhere to antidepressant and CBD, as this is the key to success. He needs to try to concentrate to work, as it may give purpose to patient's life. He needs to avoid using alcohol with the antidepressant, as it may decrease the efficacy and may augment the side effects of the antidepressant. Now moving to a second patient problem, the COPD. Starting with assessment of disease. As per GOLD guidelines, patient has uncontrolled moderate COPD and can be classified as Group B COPD. This is evident by the fact that patient's FEV1 and FVC ratio is 0.63 and his predicted post FEV1 percentage is 52%. And also the CAT score for COPD is 21. Moreover, patient complains of mild shortness of breath and trouble breathing while exercising. He does not exhibit any sign of bronchitis with his COPD. The most important contributing factor for his history of COPD is the fact that he smokes 1 pack per day. Patient is currently compliant with all of his medication and wants to obtain the treatment for his COPD. Considering all these factors, there is a need to modify his treatment for COPD to prevent disease progression and improve his exercise tolerance. The assessment of current therapy. Currently, patient is using albuterol 2 buffs as needed for the management of shortness of breath and trouble breathing while exercising. Albuterol is appropriate for symptomatic management of COPD. As per GOLD guidelines, SABA should provide to all individuals that are presented with symptoms of COPD. It improves FEV1, dyspnea, and health status of the patient. Patient also takes fluticasone for the management of COPD. Corticosteroid without LABA would not be an appropriate choice in this patient as per GOLD guidelines. Assessment of planned therapy. Currently, there is no planned therapy for the management of COPD in this patient. Patient currently taking albuterol and fluticasone for the management of COPD. As per GOLD guidelines, albuterol is only affecting patient for the relief of symptoms of COPD. However, since patients can be classified as Group B COPD, according to GOLD guidelines, there is a need to start a long-acting muscarinic agonist as per GOLD guideline. The goal of therapy in this patient is to prevent progression of COPD, decrease respiratory symptoms, and improve exercise tolerance. The contributive factor for COPD is smoking. Recommendation number 1. Stop fluticasone inhaler and start LAMA, such as tiotropium, in 18 micrograms dose once a day. LAMA, such as tiotropium, is considered the first line of treatment in patients presented with dyspnea due to COPD. Once daily dosing will provide better compliance to this patient. LAMA treatment improves symptoms and health status. LAMA also improves the effectiveness of pulmonary rehabilitation and improve exacerbation-related hospitalization. Fluticasone is considered second line of treatment in patients with COPD when other agent does not work and should be stopped in this patient. Recommendation number 2, we need to educate patient about tobacco cessation. Tobacco cessation is the single most important intervention to slow down a decline in lung function. This helps patient to gain the control of his life again, as this was the primary goal for his seeking medical help. Smoking cessation is the key to success for the treatment in this patient as well. Recommendation number 3, patient to get her influenza vaccine yearly during the month of October to November. Pneumonia vaccine is another important vaccine required to prevent pneumonia in patients who have COPD. I recommend him to get his Prevnar 13 followed by Pneumovax in about after 8 weeks. The rationale behind that is that the GOLD guidelines recommend influenza and pneumonia vaccine in patients with COPD for the prevention of lower respiratory tract infection. The monitoring, the safety, the tiotropium is very well tolerated with minimum side effects. The most common side effects with the use of tiotropium are dry mouth, constipation, and blurred vision. The efficacy of the treatment can be seen by the improvement in the exercise tolerance, less shortness of breath. Moving to patient education, it is important to go over inhaler technique initially and periodically on the subsequent visit with the patient. Patient should be aware of worsening signs and symptoms of COPD. We need to encourage patient for physical activity to improve his overall patient's health and prevent disuse atrophy. We need to advise patient to avoid exposure to polluted air and dust. And we need to educate patient that in case of worsening symptoms, he needs to take help right away.